Good morning. It feels like it's been a long day already. My name is Karen Roberts Turner, and I am from the Howard University, and I thank Dr. Shelley McDonald Pinkett for that very warm introduction. I have no relationships, financial or otherwise, that I need to disclose, so I will get right to it. My topic is ethical decision-making in diverse populations. We've heard quite a bit. Dr. Beverly, thank you for teeing up my presentation about healthcare inequity. In that inequitable model is a patient who often has limited choices, and the decisions that the patients make will obviously impact the health outcomes. So if we look at how to better equip patients to make decisions, we can also work towards achieving health equity in that manner. So the purpose of my presentation will be to examine how culture, religion, and societal values affect ethical decision-making among various patient groups, multicultural patient groups primarily. We will define ethical principles in healthcare, look at the SHARE framework for ethical decision-making, discuss influences on healthcare decisions, and then identify strategies for promoting culturally sensitive ethical practices and improving health equity in the process. What is ethical decision-making? I'm glad you asked, because I have a slide here to tell you. Ethical decision-making is just a cognitive process of deciding something, coming to making a choice. But when you ask about ethical decision-making, it encompasses the rules, the values, the beliefs, the principles, the guidelines that form our moral framework, and we rely on those to help us make our ethical decisions. There are 4 fundamental ethical principles, and if you ever have taken a healthcare ethics course, these may look familiar to you. These are not the only ethical principles that exist, but these are the 4 fundamental principles in healthcare ethics. Autonomy, thus is self-determination, the right to self-governing, the respect for persons, beneficence, the intention to do good, to promote the best interests of the larger group, non-maleficence, not doing bad, above all, do no harm, justice, the commitment to fairness, equity, and commitment to following the law. When we talk about making healthcare decisions or making any decisions, these ethical principles are not the only reference that any of us might use. We will consider our cultural influences, our religious beliefs, even our political ideologies, and we cannot forget our societal values. Dr. Beverly introduced us to a concept called cultural competence, which, thank you, but it bears repeating that as actors within the healthcare community, it is our responsibility to understand and appreciate people from other cultures, our patients, our colleagues from other cultures, and not just with an acknowledgement saying that it exists, but with a desire to appreciate and interact with members of other cultures so that they feel that they are respected, that the relationship that is built between the provider and the patient or the colleagues is one of openness and respect and compassion. And it also requires some self-awareness. We have biases. I know I do. And if everybody's honest, you know you do too. We have our own biases that we bring into the relationship with a patient. You may see, and I use this with my students, a patient may come in with a hat that has those 4 letters that I'm not going to repeat, but you may have a reaction to that patient and say, oh, they support a particular political party. I feel a certain way about that. I don't want to treat them. You don't have that choice. Or you may be the patient and a provider comes in and you just know that they don't view your same culture, they're maybe from a different culture, and that creates a bias. So cultural competence, cultural humility helps as clinicians to acknowledge, accept, and to actually do the work to eliminate that from the relationship, so that once you get into a situation where you have to present a patient with a treatment plan or a care plan and have a discussion about options to make a decision, it's a more open and respectful, less conflicted proposition. These are who patients are. They are gender differences, they are cultural differences, but when it comes to care, the care cannot be biased. So that's the background. Ethical decision-making. I like to refer to this model that was created by, or I should say formulated by the Agency for Healthcare Research and Quality, AHRQ. I'm from DC, so we use initials for everything. The SHARE model that is a clinician-led approach. It's a collaborative approach where patients and providers actually collaborate and together come to decisions that will guide the patient's care, but they are based on the patient's values and preferences. The SHARE is seeking your patient's participation, and by patient, that would include whoever the patient's decision maker is if it's not the patient, or whoever the patient wants to be involved in the decision. The H is help your patient explore the options and compare the options. Sometimes there is more than one approach to treating a condition, and there may be benefits to one that make it a better option than a different one. So helping the patient focus on those differences and what best aligns with that patient's preferences is what the A is, assess your patient's values and preferences. R is help your patient reach a decision. Patients are the ultimate decision makers. Caregivers do not make decisions for patients. The most you do for decision making is in the offering of the options. You make some educated choice about what to offer the patient, and then it's out of your hands in terms of the ultimate decision. But you are required to help your patient reach that decision by assisting with the evaluation of the options, and then once your patient makes the decision, having a conversation. Okay, what does that decision now mean now that you've reached it? When you're in a patient care relationship where your patient or your provider, you have different cultural implications, these 5 factors can impact decision-making and the outcome of your patient's care. Communication, treatment preferences, perceptions of illness and pain, the role of others, and religion. These are just a few, just to illustrate the point of how cultural differences or diversity can impact decision-making. And to the extent that decision-making in this context, if it's based on moral beliefs, ethical principles, religious beliefs, it's ethical. It's your moral decision. Let's look at communication. And we had this conversation this morning in the car. Communication encompasses not just what you say, but how you say it. And I'm going to say, if anybody in here has a Black mother, you already know what I mean. That look, that look stops you in your tracks. Well, as healthcare providers, when information is given to patients, the facial expressions, the body language, the tone can vastly impact how that information is received and understood. So in certain cultures, it's not just non-English speaking versus English speaking. It's the way you say something, the way you approach a person. Dr. Beverly mentioned older women. If you're a younger person, you don't roll up on a older person. Hey, Shirley, I heard you're sick. Shirley's going to shut down, all the way down. You have to, Miss Johnson, what brings you here today? You have to understand that part of your patient's experience. Obviously, non-English speaking patients require assisted communication through interpreters, but you also have hearing impaired patients whose I don't want to call it a disability, but whose impairment may not immediately be visible, but you as the provider need to know if you have a hearing impaired patient, you need to take the extra step of making sure that there is someone who can communicate with that patient. Cultural nuances also can affect how information is received. Patients may use slang, cultural idioms, or local dialect that may not translate well into your understanding as a clinician. Likewise, you may use terms that that patient doesn't understand. So making sure you're communicating on a level playing field has a serious impact on how the information will be received. And then also, just in terms of communicating, culturally, some people, some patients do not say a lot. They will not share a lot. They will not express pain, even if they are in pain. And Dr. Beverly referenced this, and I'm actually going to mention this later under religion. There is I'm not going to preview it, I'll wait. So there are also patients who will say they don't want to know bad information. Just don't tell me. If it's bad, don't tell me. As a clinician, you're obviously conflicted. You kind of have to give the patient information, but the patient has the right, because they have autonomy, to refuse information, to refuse treatment. So you have work to do to try to figure out how do you achieve your responsibilities as the healthcare provider to make your risk manager and your lawyer happy that you have fully advised your patient of their condition and their options and all of that. But at the same time, respecting your patient's choice not to be told. And if it's culturally or religiously motivated, then you certainly have a little more work to do to try to figure out how to resolve that. Involving others, reaching out if you have a multicultural affairs office in your institution, or even the caregivers or family members, respecting HIPAA without releasing any PHI, but having some way of communicating with the people around the patient for some support or guidance on how you might be able to get through to your patient to be able to better communicate. Your patient's selection of treatments may be impacted by their religion or culture. I'm sure we've all heard that Jehovah's Witnesses will refuse blood transfusions based on their interpretation of biblical texts that command abstention from blood. If your patient is refusing blood and you ask why, this may be the reason. And this doesn't mean that now you don't treat the patient. It means you now find alternatives for accomplishing the same goal while respecting the patient's refusal of blood. Similarly, patients may be guided by culture or religion or even societal beliefs in refusing to be vaccinated. In that situation, you likewise find some alternative if it's available. If it's not, you document. Any patient refusal, whatever the reason, and it's better to have a reason for why the patient refused, documented, and that will enable subsequent providers to understand what happened during your course of treatment and not view this as a case where either you didn't do what you were supposed to do or that this patient is not compliant or just not a cooperative patient in this process. The perception of illness is often shaped by culture or religion. As referenced earlier, a patient may not share that they are in as much pain as they are in because they may believe that that pain is a punishment for sin, it's a test of faith, or it's just part of God's plan. I have to go through this, and so I'm going to go through it. I'm not going to let you fix it, doc, because I need to go through this. This is a spiritual journey for me right now. Okay, that's that patient's choice. But understanding and respecting that is what, as you know, as the provider, you just will have to release if that is what your patient's choice is. And then really, another challenge is the patient who does not express how much pain they are actually in. There are other signs. I'm not a doctor. I do have played one on TV before, but there are other signs of pain. You will get tachycardia, right? And there may be other things that happen. So you know your patient is just sitting there. No, I'm fine. I'm fine. I'm fine. But you see things going up and down. You address that. Okay, I hear you. You say you're fine, but I see these changes. And so let's try to address that. And maybe in that way, you can connect with your patient's pain and address that. Because even if the patient wants to have the pain, you as the physician know that may not be a good thing. You know you may still need to fix whatever is causing that pain. And so you may have to do a little respectful work to get to the point where you can get to the source of whatever's causing that pain and have the patient be willing to accept what you offer. Now, I certainly could not talk about pain and pain perception without addressing the reality that in this American healthcare system, the misperception still exists that Black people can endure more pain than is reality. So that sickle cell patient who comes in, not only is he or she viewed as a drug seeker, frequent flyer, but half the time, oh, I don't believe your pain is that bad. It can't be that bad. Or you can take it, you can handle it. So non-Black physicians, and let me not even say that all Black physicians understand this, but any physician who has some bias when it comes to pain perception of any other population really does need to do some work, because diminishing or minimizing your patient's expression of any symptom, especially pain, is a sure way to have that patient's care be woefully inadequate and continue to perpetuate the inequities that we see in some of these populations. How other people are brought into the healthcare decision-making dynamic is often driven by culture or society. In American culture, we are a personal choice, independence, it's my choice, it's my decision society. But that's not the case in other cultures. So if you're a clinician thinking that your patient is going to make all of these decisions, and so that's who you're focusing on, and the patient is deferring to someone else, you have to be prepared to incorporate that someone else into the conversations. Because if the patient is deciding that they are willing to have other people or another person make their healthcare decisions, then that is their choice. Again, the patient is still autonomous, even though they're, excuse me, passing or sharing the decision elsewhere. So striking the balance between that autonomy and the collective decision-making is that's your job. That's what you have to do, because ultimately the goal is to achieve the outcome that best serves the patient's interests, even if that decision is not made by the patient. Religion and spirituality have direct impacts on decisions. A Catholic patient may refuse to be a living donor for a sibling, even though, why wouldn't you want to give your kidney to your sister? She will die without it. But their religious belief is that she can't, because organs are not supposed to be removed until somebody is actually dead. So it's not that she doesn't want to, so she shouldn't be judged for not agreeing. She should be respected, and the conversation should be gentle and more compassionate, and maybe what other options do we have? Similarly, a female Muslim patient may not want to talk about her urologic or GYN issues with a male doctor. It's not that she doesn't want to talk, it's just talking about something that's sensitive with a man. You recognize that, oh, okay, well, I will bring in a female physician or a nurse or somebody that you can communicate openly with. And other faith traditions may have certain requirements for how end of life or life support and tube feedings are conducted. So if you have a person of the Jewish faith, they may need to consult with a rabbi first about tube feedings and end of life care. Well, you give them the space to do that without, oh, we have to make this decision right now. No, you don't have time to do that. If that's what their faith or their culture requires, then you extend the courtesy of allowing that to happen. Sometimes, like with the autopsy, the refusal may not be just, oh, I don't want an autopsy. It may be that their faith or their culture prohibits autopsies. And if that is the case, no matter how important you as the clinician or the researcher may want that, you have to respect that person's faith. And feel free to document that this patient declined an autopsy because, but don't make it sound like they did something wrong by saying no. And certain end-of-life care, many people of faith would want to have a faith leader, a pastor, a rabbi, someone at the end of life. And so to give the patient and the patient's family the courtesy of being able to do that will certainly make the family, that process of losing a loved one go more peacefully. So how do we get to a framework where we are able to have patients feel like they are able to express themselves and make ethical decisions in situations where either they or their providers are of different cultures? One of the first ways is to learn that about your patient. If you have a relationship with the patient as a primary care, it's a little easier, but if you're just encountering a patient in a hospital setting, you still have the opportunity to understand and get to know and involve family members or caregivers to help you understand the do's and don'ts. Having that information will be very helpful as you guide yourself in that course, and also as you develop your treatment plan. Integrating any type of recommendation or health initiative that the patient suggests, if it's possible to incorporate that into your care plan, that's one way that you are showing that you're recognizing that they have a certain faith tradition. For example, if the patient requires prayer at a certain time, well, you make it possible for that to happen. You don't, if you can, don't schedule a test at a time where you know the patient has already said they need to be praying. That will help. It may not help the condition, the medical condition, but it'll certainly help the emotional and mental and spiritual condition of your patient, which certainly can impact their ultimate health outcome. In general, having an educated and informed workforce, your staff, not just medical or clinical staff, but any staff that may encounter the patient. Your frontline staff are often the first impression that any patient will have of your institution. And if the respect begins there, then you'll probably have a much happier patient by the time you get into the examining room. Be okay with acknowledging that we don't know everything. We don't have all the answers. There may be traditions from other cultures that work. And if that is what this particular patient chooses and it doesn't conflict with your integrity as a professional integrity to let them do that, then find a way, if you can, to incorporate that or to allow for that in that patient's care plan. We have sort of at every hospital that I've been connected with, Multicultural Affairs Office. I think that a lot of them are limited to interpreters. Well, there's so much more to this process than just interpretation. Just the educating about other cultures and understanding health traditions of other cultures would be an addition that any multicultural affairs office or service could provide. And it will help all the staff when they encounter some of these issues and provide resources for how to navigate when confronted with them. But having staff, clinicians, nursing, unit clerks of varying backgrounds also makes it for an easier environment to navigate when you know, oh, this is someone who's from X, Y, and Z. Well, we have someone here who's from X, Y, and Z, so let's see if we can talk to that person or have that person come talk to this patient so we can come to a better understanding for how we will navigate this process. And that representation should not only be on the workforce side, but also on the research side, because we know that research is what dictates a lot of the medicine that we practice. I'll say we. But it dictates the understanding that we have of patient populations. And if that research is only based on white men from Ireland or Europe, it's not ever going to be applicable to us, and there will always be a disconnect. So making sure that we're advancing representation in clinical research studies, in the workforce, but also we have to make sure it's represented in these large language models that AI is now based on, because that will kick out some information that has absolutely no relevance to the patient population in Brownsville or in Prince George's County, Maryland, or in Washington, D.C. And so that will definitely require some major work to right that wrong. So just to conclude, and I don't think I put a concluding slide, diversity impacts decision-making in such areas as communication, the perception of illness and pain, in the selection of treatment options, in the role of others in the healthcare profession, and in the expression of religion. Promoting ethical decision-making among diverse patient groups has to be intentional and encompass understanding and interacting with patients of different cultures, engaging in learning, ongoing learning. It's not just one seminar and now you're an expert, an ongoing learning experience that includes self-reflection and acknowledgement of biases, and then a commitment to correcting whatever those biases might be. And doing that will create a more open and respectful relationship where patients, regardless of their background, culture, ethnicity, belief, gender, gender identity, gender expression, can collaborate with healthcare decision makers, healthcare providers, and decision makers to reach conclusions that are informed and that align with the patient's values. And in the end, that will improve health equity. Thank you.